Welcome back to the Deep Dive. Today, we're tackling a specific request from one of you listeners. It's about taking some pretty dense revision notes and turning them into something, you know, genuinely useful.
Yeah, something high yield, easy to digest, and hopefully something that actually sticks when you need it.
Exactly. We're diving into epistaxis, that's the medical term for nosebleeds, and we're doing it using MSRA revision notes as our guide.
That's right. Think of it like we're mining those notes for the absolute key info, cutting out the extra stuff and just getting to what you really need to know, but, in a way that makes sense, like we're chatting about it.
So our plan is to walk you through it all. We'll cover the definition, what causes it, the risks, how it actually happens, what else it might look like.
Differentials, yeah.
Right. And who tends to get it, what you'll actually see, how you figure it out, and maybe most importantly, what you should do about it. Plus, the outlook and what can go wrong.
Basically, everything you'd need for a really solid grasp. Let's get started.
All right, first things first. Let's get a clear definition. What exactly are we talking about with epistaxis?
Okay, so at its heart, epistaxis is just bleeding from the blood vessels inside the nose. It might pop up spontaneously, seemingly out of nowhere.
Like just sitting there and suddenly?
Yeah, or it could be from, say, trauma, like a knock to the nose, or it might even signal some underlying health issue.
Okay, pretty straightforward definition. But the notes immediately make a big distinction, don't they? A fundamental classification.
They do, and this is crucial. You have to differentiate between anterior and posterior bleeds. It's not just terminology. It shapes everything, how you assess it, how you manage it.
Anterior versus posterior.
Yeah.
So break that down for us. What's the difference and why does it matter so much?
Okay. Anterior bleeds are the most common, by far. The bleeding source is usually up front. You can often see it if you look carefully inside the nostril. It's typically coming from this dense network of tiny capillaries called Kiesselbach's plexus.
Sometimes called Little's area?
That's the one. Think of it as the front of the nosebleed. Now, posterior bleeds, they're different. They start deeper in the nasal cavity, often from bigger vessels, like branches of the sphenopalatine artery.
And these are less common, you said?
Less common, yeah, but generally more serious. They tend to bleed much more heavily. More profuse is the word used. And because the blood flows backwards down the throat.
That's the key risk.
Exactly. There's a higher risk of aspiration, of airway compromise. You really need to be alert to that possibility.
Got it. So that distinction is critical for you assessing the situation.
Yeah.
Anterior. Usually less worrying, visible source. Posterior. Potentially serious, hidden source, big airway risk.
Precisely. It guides your whole approach.
Okay, so we know what it is, the two main types. Let's move on to the why. What actually causes a nosebleed? What are the triggers, the underlying problems? Let's unpack the etiology section from the notes.
Well, the most common reason, maybe surprisingly, is often just dryness and irritation of the nasal lining, the mucosa. That thin lining gets fragile, the little vessels break easily.
Makes sense, especially in winter with central heating or very dry climates.
Absolutely. But the list of causes goes way beyond just dryness. Trauma is a huge one. That includes, yes, nose picking, which is incredibly common, especially with kids.
We've all seen it.
Or, a direct blow to the face, or even kids putting small objects up their nose, foreign bodies. Then you get into systemic conditions.
Right. The notes mention some specific ones.
Yeah, things that affect blood clotting. So bleeding disorders like immune thrombocytopenia, that's low platelets, or even conditions like Waldenstrom's macroglobulinemia, which affects blood thickness and clotting factors.
So some quite serious underlying conditions can present this way.
Definitely. The notes also list juvenile angiofibroma. That's a benign tumor, but it can be aggressive locally, usually in teenage boys. Cocaine use is another one. It constricts blood vessels, but also damages the lining badly over time. Then there's HHT, hereditary hemorrhagic telangiectasia, a genetic thing causing fragile blood vessels. And inflammatory conditions like GPA, granulomatosis with polyangiitis, which causes inflammation in blood vessels, often affecting the nose and sinuses first.
Wow, quite a list. Now, hypertension, high blood pressure. That's often linked with nosebleeds in people's minds, isn't it?
It is, and the notes offer a really important clarification here. It's very common for someone's blood pressure to be high during an acute bleed. Often, that's just down to the stress and anxiety of bleeding.
The sight of blood can do that.
For sure. But the notes suggest that people who get nosebleeds aren't necessarily more likely to have undiagnosed high blood pressure compared to anyone else. However, And this is the really interesting bit.
Oh,
Having established pre-existing hypertension does seem to increase the risk of having a more severe bleed or one that lasts longer.
so it's more about the severity and duration
Mhm.
if you already have high blood pressure rather than it being the initial cause necessarily.
That seems to be the nuance the source material points to. Unless, of course, that hypertension is part of a bigger picture affecting blood vessels generally.
Right, that's a key distinction for you to remember. Okay, building on causes, let's shift to risk factors. Things that just make you generally more prone to getting a nosebleed or a bad one.
Yeah, and these tie back into the causes quite neatly. Living in dry places, low humidity environments, any kind of nasal trauma, including that habitual nose picking, chronic nasal issues like infections or allergies, basically anything causing ongoing inflammation. High blood pressure, as we just discussed, particularly for severity, underlying blood clotting problems, obviously, and critically, medications.
Which one specifically?
Big ones are anticoagulants and antiplatelets. So warfarin, clopidogrel, aspirin, these significantly increase the risk or severity. Also, even things like overusing or misusing decongestant nasal sprays can damage the lining over time.
So these are all flags.
Yeah.
If you were assessing someone with epistaxis, these risk factors are exactly what you need to be asking about in their history. They're vital clues.
Absolutely. Helps you paint the picture.
Okay, let's just quickly touch on the mechanism. How does the bleeding actually happen physiologically? Pathophysiology.
The notes keep it pretty simple. Essentially, it boils down to a rupture of those blood vessels in the nasal mucosa. Something makes them fragile dryness, inflammation, trauma, underlying vessel abnormality or directly damages them, and boom, you get a bleed.
Simple mechanics. Got it.
Yeah.
Now, sometimes blood seemingly coming from the nose might not be straightforward epistaxis.
Yeah.
What else should be on your radar? The differential diagnoses.
Good point. You need to think, could this be something else presenting as a nosebleed? The notes mention obvious things like direct nasal trauma itself or a foreign body stuck up there, which can be both a cause and the main diagnosis.
Right.
Sinusitis or nasal polyps can sometimes cause blood-tinged discharge, which might look like a mild bleed. HHT, which we mentioned as a cause, is also a key differential for recurrent severe bleeds. And the really important one to not miss is tumors.
Nasal or nasopharyngeal tumors.
Exactly, especially if the bleeding is one-sided, persistent, or comes with other red flag symptoms like pain, blockage, or neurological signs.
So the takeaway here for you is most nosebleeds are simple, but always keep these other possibilities in mind, especially if things seem a bit unusual if it keeps happening or if there are other symptoms. It just reinforces why a good clinical assessment is so vital.
It really does. You can't be complacent.
Speaking of assessment, let's talk numbers. Who actually gets epistaxis? How common is it? The notes gave some UK-specific data.
Yeah, it's extremely common. The overall UK prevalence mentioned is around 60 cases per 100,000 people per year. But the interesting thing is the age distribution.
It's not even across the board.
No, it shows what we call a bimodal pattern. There's a peak in young children, typically ages 2 to 10. Then the incidence dips and peaks again in older adults, sort of 50 to 80 years old.
Two main groups then.
Exactly. It affects both sexes pretty equally overall, but there is a slightly higher incidence noted specifically in older adults.
So that gives you a mental picture of who's most likely coming in with this. Little kids, often maybe from picking,
Usually anterior bleeds, yeah.
and older adults, potentially with more complex causes, maybe posterior bleeds, maybe on medications. That age pattern is a good thing to remember.
Definitely useful context.
Okay, let's get practical. You've got a patient in front of you, maybe actively bleeding. What signs and symptoms are you looking for, and what are the absolute must-ask questions for the history?
Well, obviously you'll see blood coming from one or maybe both nostrils. The key observation linking back to our classification is where is it coming from? Is it dripping out the front? That points to anterior. Or are they telling you they can feel it, or are they spitting out blood? That strongly suggests it's running down the back of the throat, a posterior bleed.
Okay.
You might see clots. They might also mention feeling congested in their nose or maybe some localized pain.
And the history, this is where you really need to focus to gather those clues. What are the essential questions?
First, try to establish the site, if possible, front or back. Then, any trauma. And you might need to ask directly but gently about nose picking.
Okay, what about background?
Definitely dive into their medical history, any personal or family history of bleeding problems, clotting disorders, diagnosed hypertension, never had nasal surgery before. And medications, this is non-negotiable. You must know if they're taking aspirin, clopidogrel, warfarin, or any other blood thinners like DOACs. That's a huge factor.
Critical info.
Yeah.
And what about those other diagnoses, the differentials? Are there specific questions for those? The notes mention facial pain or ear pain.
Yes, definitely ask about facial pain or otalgia, which is ear pain. Why? Because persistent pain, especially unilateral, alongside a nosebleed, could be a red flag for a nasopharyngeal tumor.
Right, a sinister sign potentially, so don't miss that question.
Absolutely. And the nose also highlights specific things to ask young male patients, particularly if they have recurrent or significant bleeds.
What sort of things?
Ask about nasal obstruction, difficulty breathing through the nose, headache, a persistent runny nose, rhinorrhea, or any changes in their sense of smell, anosmia. In that specific group, young males, those symptoms together could point towards that juvenile nasopharyngeal angiofibroma we mentioned earlier.
Got it. So these history questions are really your toolkit. They help you narrow down the cause, judge the severity, identify the type of bleed, and screen for those rarer, more serious possibilities. Maybe a quick memory aid for history. The notes didn't explicitly give one, but we could maybe think like, when did it start? Where's it coming from? Front, back. How did it start? Trauma, spontaneous. Then any other problems? Pain, blockages, smell. And background medical history and meds, like WWH, AOBM.
Yeah, something like that could work. A framework to make sure you cover the bases quickly. WWH-AOBM. When, where, how, any other problems, background medical meds, not bad.
Okay, so you've done your history, had a look. Do most people with nosebleeds need a load of tests?
No, definitely not. The notes are very clear on this. Diagnosis is mostly clinical. For the vast majority of simple, straightforward epistaxis cases, you do not need extensive investigations.
That's good to know. So when do you need to start thinking about tests?
You consider investigations mainly for recurrent bleeds, very severe bleeds, or if your history and examination just don't feel right if there are red flags suggesting something else is going on.
And in those cases, what tests are we talking about?
Blood tests become important then. You'd want a full blood count, or FBC, coagulation studies checking things like INR and APTT, and blood typing especially if the bleeding is heavy, in case they need transfusion.
What are you hoping to find or rule out with those bloods?
Well, the FBC can show if they've become significantly anemic from blood loss, maybe chronic loss over time. It could even rarely point towards an underlying blood cancer, a hematological malignancy.
Yeah.
The coagulation screen checks if their blood clotting is normal, essential if you suspect a bleeding disorder, or if they're on anticoagulants.
Makes sense. And when does an ENT specialist need to get involved?
You'd refer to ENT if you have a strong suspicion of something like nasal malignancy, that juvenile angiofibroma, or maybe some other structural issue that needs expert assessment and potentially intervention, or if the bleeding is proving really difficult to control.
And what investigations might the ENT team do?
In those specific scenarios, the notes mention imaging, typically a CT scan of the sinuses and nasal area, and/or they might perform nasopharyngoscopy.
Which is?
That's where they use a thin, flexible camera passed up the nose to get a direct look at the nasal cavity and the area at the back of the nose, the nasopharynx. Lets them see deeper structures and potential bleeding points or growths.
So the main message for you is, simple bleed, clinical assessment is usually king. Only investigate further or refer if there are clear red flags, severity, recurrence, or other concerning symptoms.
Exactly right. History and exam first.
Okay, let's get to the really practical bit. Someone's nose is bleeding right now. What do you do? Let's walk through the management steps from these UK notes.
Right. First aid.
Yeah.
Initial management. What you or the patient can do immediately. The absolute classic, and it works often, is pinch the soft part of the nose, the fleshy bit below the bony bridge firmly.
How long for?
Hold that pressure continuously for at least 10, maybe 15 minutes. And crucially, the person needs to lean forward, not tilt their head back. Leaning forward stops the blood going down the throat.
Okay, pinch soft part, lean forward 10-15 minutes. Anything else?
Ice packs can be applied to the bridge of the nose or maybe the back of the neck. The evidence is maybe less robust than for pressure, but it might help constrict vessels. The notes also mention considering topical antiseptics if needed, maybe like Naseptin cream later to prevent crusting and infection. And a key point on admission, the notes state that patients with significant other health problems, comorbidities, or children under 2 years old with epistaxis generally warrant admission for observation or management.
Good flags for admission there. Okay, let's say the bleeding stops with pressure. What advice do you give them afterwards to stop it restarting? The self-care advice.
Yeah, this is important. Tell them to avoid anything that could disturb the clot or increase nasal blood pressure for the next day or so. That means no vigorous nose blowing, no nose picking.
Definitely no pizza.
Avoid heavy lifting or straining. No strenuous exercise. Try not to lie completely flat, maybe prop up on a couple of pillows. Avoid alcohol and very hot drinks or hot bath showers as they can dilate blood vessels. Using a little petroleum jelly just inside the nostrils or a saline nasal spray can also help keep things moist and prevent recurrence if dryness was a factor.
Okay, good practical tips. But what if that simple pressure and leaning forward doesn't work after a decent try?
Right. If first aid fails, you move to the next level. This usually involves trying to stop the bleeding directly. If you can actually see the bleeding point, typically an anterior one on Kiesselbach's plexus, the next step is cauterization.
Using what?
Commonly, silver nitrate sticks. It's a chemical cautery. But, really important, the notes stress you need to use a topical anesthetic spray inside the nostril first. Let it work for a few minutes. Cautery without anesthetic is pretty uncomfortable.
Anesthetic first, then cautery. Got it. What if you can't see a clear point or cautery fails?
Then the next step is usually nasal packing. This means putting some kind of material into the nasal cavity to apply direct pressure internally onto the bleeding site. Again, anesthetic spray before you start packing.
And how do you do the packing?
Keep the patient sitting up, leaning slightly forward. You insert the packing material, could be special nasal tampons that expand, or ribbon gauze. The notes mention thinking about cosmetic changes if the packing is bulky, and sometimes considering packing the other nostril as well.
Why the other nostril?
It can provide counter pressure against the septum, the middle wall, potentially helping to compress bleeding points there, and stops the septum bulging over if you pack one side very tightly. But that's often more of an ENT thing. If bleeding continues even after packing, the patient probably needs admitting for more specialist assessment.
Okay. And what about the really scary ones? The patient who's clearly unstable from blood loss.
Yeah, if someone comes in with massive bleeding, looking pale, sweaty, fast heart rate, low blood pressure, hemodynamically unstable, they need immediate transfer to the emergency department. Resuscitation and stopping the bleeding are the priorities. The notes explicitly say you should admit patients if you don't know where the bleeding is coming from, or if you confirm it's posterior because the risks are higher.
And if absolutely nothing is working, those resistant cases.
For those rare, truly stubborn bleeds where packing and other measures fail, surgical options come into play. The notes mentions phenylpalatine artery ligation specifically. That's where a surgeon goes in, often endoscopically now, and ties off or clips the main artery supplying the back part of the nose. It's usually a last resort.
Just to circle back on cautery, silver nitrate was mentioned, and electrocautery.
Yes. Silver nitrate is the chemical stick, good for visible vessels, often anteriorly. Electrocautery uses heat, like diathermy. It might be used for broader areas of oozing on the nasal lining, perhaps in a more controlled setting like theater or by ENT.
And the packs, they sound useful, but potentially uncomfortable or risky.
They can be, yes. Discomfort is common. They can block breathing, affect smell temporarily. There's a risk of infection, hence the common practice of giving antibiotics, like amoxicillin, which is specifically named in the notes, while the pack is in. There's also a risk of pressure necrosis tissue damage if left too long, potentially leading to a septal perforation. And a posterior pack slipping is a serious airway risk.
How long do packs usually stay in?
Typically removed after a few days, according to the notes, and ideally by an ENT specialist or someone experienced.
Okay, that covers the management spectrum pretty thoroughly. So what's the usual outcome? The prognosis?
Generally, it's very good. The notes say the prognosis is favorable. Most nosebleeds either stop on their own or respond well to those simple first aid or initial clinical measures like pressure or cautery.
That's reassuring for most people experiencing one.
It is. But, as we said, the notes do highlight that recurrent bleeds, or particularly severe ones, obviously need a closer look, further investigation, and maybe more complex management.
And complications, even if rare.
Potential complications are listed. Anemia is one, especially if the bleeds are frequent or heavy over time, leading to chronic loss. Nasal septal perforation, that hole in the middle wall, can happen, often linked back to picking, trauma, cocaine use, or sometimes complications from packing or cautery, and potentially damage to other nasal structures during procedures. But mortality, death from a nosebleed, is stated as being extremely rare. It's usually only seen with massive, uncontrolled hemorrhage or in patients who are already very frail with significant comorbidities.
Okay, let's just clearly list those complications one more time for you listening, things to be aware of.
Sure. So the main ones are recurrent bleeding itself, anemia from blood loss, infection, particularly associated with nasal packing, nasal septal perforation, and potential damage to adjacent structures during treatment.
Re-emphasizing that mortality point, very rare, usually linked to severity in vulnerable patients.
Correct. And the final key takeaway from the source on this is really about prevention of complications. Prompt management, doing the right things early, and appropriate follow-up, especially for those difficult cases, is the best way to ensure good outcome and avoid problems down the line.
That really covers the ground well. We've gone through this deep dive into Epistaxis, taking those MSRA revision notes, and hopefully pulling out the really crucial high-yield information that you need to understand it and feel more confident managing it.
Yeah, it's such a common thing to see, but as we've discussed, there's quite a spectrum from, a minor annoyance to something signaling a significant underlying issue that needs urgent attention.
Absolutely. Which leads nicely to a final thought, something for you to maybe reflect on, drawn from thinking about this material. It's how this really common symptom, a simple nosebleed, can occasionally be the very first clue to something much bigger. Maybe a hidden bleeding disorder, maybe a tumor starting, or uncontrolled systemic disease. It just underlines why taking that careful, thorough history is so important every time, even for things you might see multiple times a day. Don't just assume it's simple.
That's a great point. Never underestimate the basics. And for anyone wanting to look at revision materials similar to the notes we've drawn on today, you can find resources over at passthemsra.com and freemsra.com.
Excellent resources for anyone preparing for the MSRA. Definitely check those out. Thanks for joining us on this deep dive. Keep digging deeper, keep learning. We'll catch you on the next one.